Dr. Sarah Chen adjusted her surgical mask one more time as she walked through the pristine corridors of St. Mary's Medical Center. The fluorescent lights cast harsh shadows across her face, highlighting the exhaustion that had become her constant companion over the past 6 months. Her footsteps echoed softly against the polished floors, a rhythmic reminder of her temporary status in this prestigious hospital. Sarah had arrived at St. Mary's through a staffing agency, filling in for Dr. Marcus Rivera, who had taken an extended leave for a family emergency. From the moment she stepped into the hospital, she could feel the weight of skeptical glances and whispered conversations that followed her everywhere. The permanent staff made no effort to hide their doubts about the temp doctor who had been thrust into their carefully orchestrated world. The morning briefing in the surgical department was always the same routine. Dr. Harrison Webb, the chief of surgery, would review the day's schedule with his usual commanding presence. His silver hair was perfectly groomed, and his crisp white coat bore the authority of someone who had spent 30 years building his reputation at St. Mary's. When he spoke, the room fell silent, and every resident and nurse hung on his words. "Today we have 7 scheduled procedures," Dr. Webb announced, his voice carrying across the conference room. "Dr. Martinez will handle the cardiac bypass, Dr. Thompson has the liver resection, and Dr. Chen." He paused, his eyes finding Sarah in the back of the room. "Dr. Chen will be observing the gallbladder removal with Dr. Peterson." Sarah felt her jaw clench. Observing. Again. Despite having completed her residency with honors and working as a trauma surgeon for 8 years before coming to St. Mary's, she was consistently relegated to minor procedures or observer roles. The message was clear: temporary staff were not trusted with the complex cases that defined the hospital's reputation. After the briefing, Sarah made her way to the surgeon's lounge, hoping for a quiet moment with her coffee before the day began. The room was spacious, with leather chairs arranged around small tables and large windows overlooking the city. Several doctors were already there, their conversations flowing easily among colleagues who had worked together for years. Dr. Jennifer Martinez looked up as Sarah entered. Jennifer was one of the few doctors who had shown any warmth toward Sarah since her arrival. "Morning, Sarah. Ready for another exciting day of observation?" The sarcasm in Jennifer's voice was gentle, more supportive than mocking. She had been at St. Mary's for 12 years and understood the politics of the surgical department better than most. Jennifer had witnessed how the hospital treated temporary staff, especially those who hadn't come through the traditional channels of medical school connections and family legacies. "I keep telling myself it's only temporary," Sarah replied, pouring coffee into a paper cup. The irony of her words wasn't lost on either of them. "You know," Jennifer said, lowering her voice, "I've seen your file. Your surgical scores from residency were in the 98th percentile. Your trauma experience is more extensive than half the surgeons here. Webb's just being territorial." Sarah appreciated Jennifer's support, but she had heard similar reassurances before. The reality was that St. Mary's operated on an unspoken hierarchy that placed temporary staff at the bottom, regardless of their qualifications. She had learned to navigate this environment by keeping her head down, doing her assigned tasks without complaint, and waiting for her contract to end. The morning observation with Dr. Peterson was routine. The gallbladder removal proceeded without complications, and Sarah found herself anticipating the surgeon's moves before he made them. She could see alternative approaches that might have been more efficient, notice subtle signs that suggested adjustments to the standard procedure, but she remained silent. Temporary surgeons offered observations only when specifically asked, which was rarely. During lunch break, Sarah retreated to the hospital cafeteria. The large room buzzed with conversation from doctors, nurses, and staff members sharing their daily experiences. Sarah typically sat alone, using the time to review medical journals on her tablet or catch up on continuing education requirements. She had learned that attempting to join conversations often resulted in awkward silences or polite but dismissive responses. Today, however, her solitude was interrupted by Dr. Amanda Foster, one of the emergency department physicians. Amanda slid into the chair across from Sarah with a purposeful energy that immediately caught her attention. "I've been meaning to talk to you," Amanda said, unwrapping her sandwich. "I heard about your background in trauma surgery. We've been getting more complex emergency cases lately, and, honestly, some of our surgical consultations have been sluggish. Sarah raised an eyebrow. It wasn't unusual for tensions to exist between the emergency department and surgery. Emergency physicians often felt that surgeons took too long to respond to urgent cases, while surgeons believed that emergency doctors were too quick to request surgical intervention. What kind of cases? Sarah asked, genuinely curious. Last week we had a motorcycle accident victim with internal bleeding. It took 45 minutes to get a surgical consult, and, by the time they got him to the OR, he'd lost so much blood that the surgery took twice as long as it should have. The surgeon kept saying they needed to wait for better imaging, more labs, additional consultations. Sarah nodded thoughtfully. In trauma surgery, time was often more critical than perfect information. Sometimes you had to make decisions based on clinical judgment rather than waiting for every possible test result. It was a different mindset from elective surgery, where thorough preparation was not only possible but expected. The thing is, Amanda continued, I've reviewed some of the emergency surgical cases from other hospitals where you've worked. Your response times were impressive, and your outcomes were consistently good. I just think it's a waste to have someone with your experience sitting in observation rooms. Their conversation was interrupted by the arrival of Dr. Kevin Walsh, one of the senior surgical residents. Kevin had the confidence that came from knowing his future at St. Mary's was secure, assuming he continued to meet expectations. His family had connections to the hospital board, and his father was a prominent surgeon in the city. Dr. Chen, Kevin said with a smile that didn't quite reach his eyes. How's the temp life treating you? Learning a lot from observation? Sarah forced a polite smile. Every case is educational. That's great to hear. You know, I was just talking to Dr. Webb about the upcoming trauma rotation assignments. He mentioned that permanent residents get priority for hands-on experience. Makes sense, right? Investment in long-term staff and all that. The message was clear, and Kevin delivered it with the casual cruelty of someone who had never questioned his own privileged position. Amanda's expression darkened, but she remained silent. Hospital politics were complicated, and challenging residents connected to the administration was rarely worth the potential consequences. After Kevin left, Amanda leaned forward. See what I mean? This place has a serious problem with recognizing talent when it doesn't come wrapped in the right packaging. Sarah appreciated Amanda's frustration, but she had made peace with her situation months ago. I'm not here to change the culture, Amanda. I'm here to fulfill my contract and move on. Fighting the system just makes everything harder. Maybe, Amanda replied. But what if the system needs fighting? What if patients are suffering because qualified doctors are being sidelined for political reasons? The afternoon brought more of the same routine. Sarah attended another surgery as an observer, this time watching Dr. Thompson perform an appendectomy. The procedure was straightforward, but Sarah noticed several moments where Thompson's technique could have been refined. His suturing was adequate but not efficient, and his approach to accessing the appendix created unnecessary tissue trauma. During the postoperative discussion, Thompson addressed his comments primarily to the residents, occasionally acknowledging Sarah's presence with brief eye contact. When one resident asked about alternative surgical approaches, Thompson dismissed the question with a wave of his hand. The technique I used is the standard approach taught at this institution, he said firmly. Innovation is fine in research settings, but patient care requires proven methods. Sarah bit her tongue. She had performed hundreds of appendectomies using minimally invasive techniques that reduced patient recovery time and decreased the risk of complications. But suggesting improvements as a temporary surgeon would be seen as overstepping boundaries, not helpful contribution. The day ended with Sarah completing her documentation and preparing to leave the hospital. As she walked through the parking garage, her phone buzzed with a text message from her mentor, Dr. Elizabeth Kumar, who had guided Sarah through her residency years ago. How's the assignment going? Still planning to finish out the contract? Sarah paused beside her car, considering her response. Dr. Kumar had been instrumental in helping Sarah develop her surgical skills and confidence. She had also been the one to encourage Sarah to take the temporary position at St. Mary's, believing that exposure to different hospital cultures would make her a more well-rounded surgeon. "It's challenging," Sarah typed back. "Not the surgery itself, but navigating the politics. I'm basically a highly qualified observer most days." Dr. Kumar's response came quickly. "Patience, Sarah. Sometimes the best opportunities come from the most frustrating circumstances. Keep your skills sharp and stay ready for anything." As Sarah drove home through the city traffic, she reflected on her mentor's words. Stay ready for anything. The advice was sound, but staying ready was becoming increasingly difficult when she spent most of her time watching other people operate. Her apartment was a modest one-bedroom unit about 20 minutes from the hospital. Sarah had chosen it specifically for the short commute, knowing that emergency calls could come at any hour. The living room was sparsely furnished, reflecting her temporary status not just at the hospital but in the city itself. A few medical textbooks sat on the coffee table, and her laptop was usually open to surgical journals or continuing education modules. That evening, Sarah prepared a simple dinner and settled in to review the day's cases. She had developed a habit of mentally rehearsing procedures she had observed, analyzing what she would have done differently and researching any techniques or approaches that were unfamiliar to her. It was her way of staying mentally sharp despite the limited hands-on experience. As she reviewed notes from the appendectomy observation, Sarah pulled up recent research on laparoscopic techniques. The studies consistently showed improved patient outcomes with minimally invasive approaches, faster recovery times, and reduced hospital stays. She wondered if Dr. Thompson was familiar with the latest research or if St. Mary's simply preferred traditional methods regardless of advancing evidence. Her phone rang around 9 o'clock. The caller ID showed St. Mary's Medical Center. "Dr. Chen, this is Amanda Foster in emergency. I know you're off duty, but I wanted to give you a heads up. We just received word about a multi-vehicle accident on the interstate. Multiple casualties are coming in, and we're going to need all hands on deck. Can you come in?" Sarah was already reaching for her shoes. "I'll be there in 15 minutes. Thanks. And, Sarah? Dr. Webb isn't here tonight. Dr. Martinez is the senior surgeon on call, and she specifically requested you for the trauma team." As Sarah drove back to the hospital, she felt a familiar surge of adrenaline. This was what she had trained for, what she excelled at. Emergency trauma surgery required quick thinking, decisive action, and the ability to work under pressure. For the first time in months, she would have the opportunity to use her skills for something more than observation. The emergency department was already bustling with activity when Sarah arrived. Nurses were preparing trauma bays, blood bank technicians were ensuring adequate supplies, and the surgical team was reviewing protocols for mass casualty events. Amanda Foster spotted Sarah immediately and waved her over. "Here's what we know," Amanda said, pulling up information on her computer. 5-car accident, possible fatalities at the scene. We're expecting 4 critical patients, ETA 10 minutes for the first ambulance. Dr. Martinez wants you to take primary on whatever comes through those doors first." Sarah nodded, feeling her training take over. The months of frustration and political maneuvering faded into the background as she focused on preparing for the incoming patients. She quickly reviewed the trauma protocols specific to St. Mary's, noting any differences from hospitals where she had previously worked. Dr. Martinez appeared at her side, already dressed in scrubs. "Sarah, I need you to know that tonight, you're not a temporary surgeon. You're a trauma surgeon, period. I don't care what Webb thinks about temp staff. These patients need your expertise." The first ambulance arrived exactly when predicted. The paramedics rushed through the emergency entrance, their report crisp and urgent. 23-year-old male, driver of vehicle 2, significant abdominal trauma, possible internal bleeding, vitals dropping fast. Sarah stepped forward, her voice calm and authoritative. "Trauma Bay 1. Let's go." The trauma bay erupted into controlled chaos as the paramedics transferred the young man onto the hospital gurney. Sarah's hands moved with practiced efficiency, her eyes quickly assessing the patient while her mind processed the stream of information from the paramedics. Blood pressure dropping, heart rate elevated, signs of shock becoming more pronounced with each passing minute. "What's his name?" Sarah asked as she began her primary assessment. "Michael Torres, 23 years old," the lead paramedic replied. Paramedic found him conscious at the scene, but he's been drifting in and out during transport. Sarah leaned over the patient, speaking clearly. "Michael, can you hear me? My name is Dr. Chen. You've been in an accident, and we're going to take care of you." Michael's eyes fluttered open, unfocused but responsive. "My stomach hurts so bad," he whispered. Sarah nodded, her hands already palpating his abdomen. The rigidity and tenderness she felt confirmed her initial suspicion of internal bleeding. "I know it hurts, Michael. We're going to get you some pain medicine and fix what's wrong." The nursing team worked seamlessly around her, establishing access, drawing blood for immediate laboratory analysis, and connecting monitoring equipment. Sarah had worked with emergency teams at several hospitals, and she was impressed by the efficiency of St. Mary's trauma response. Despite the hospital's political issues, the clinical care was undeniably excellent. Dr. Chen called Lisa, one of the trauma nurses. "Blood pressure is dropping. 85/50. Sarah glanced at the monitor, noting the concerning trend. "Let's get 2 units of O- started immediately. I need a portable ultrasound and we need to move to the OR within the next 10 minutes. Dr. Martinez appeared at Sarah's shoulder. "What's your assessment?" "Blunt abdominal trauma with signs of internal hemorrhage," Sarah replied without taking her eyes off the patient. "Based on the mechanism of injury and clinical presentation, I'm suspecting splenic laceration, possibly with active bleeding. He needs emergency surgery." "Agreed. OR-3 is being prepared. What do you need?" Sarah appreciated that Martinez wasn't questioning her judgment or asking for additional consultations. In trauma surgery, delayed decisions could mean the difference between life and death. "I'll need an anesthesiologist immediately, blood bank should prepare for massive transfusion protocol, and we should notify vascular surgery just in case we encounter unexpected complications." As the team prepared to transport Michael to the operating room, the second ambulance arrived. Sarah could hear the commotion from the emergency entrance as another trauma team mobilized. The third and fourth ambulances would follow soon, each bringing patients who needed immediate medical attention. In the elevator to the surgical floor, Sarah focused her mind on the upcoming procedure. She had performed dozens of emergency spleen surgeries, but each case presented unique challenges. The patient's young age worked in his favor, but the signs of ongoing bleeding meant time was critical. The operating room was prepared and waiting when they arrived. Dr. Lisa Park, the anesthesiologist, was already reviewing Michael's medical information and preparing for rapid sequence induction. The surgical technician had the instruments laid out according to the trauma surgery preference card, and the circulating nurse was confirming the patient's identity and procedure. "Michael Torres, emergency exploratory laparotomy for suspected internal bleeding," the nurse announced as part of the standard safety protocol. "Confirmed," Sarah replied, scrubbing in at the sink outside the OR. The familiar ritual of surgical preparation helped focus her mind on the task ahead. Hot water, methodical scrubbing, the feel of the sterile gown and gloves. These routine actions created a mental transition from the urgent chaos of the emergency department to the controlled precision required in the operating room. As Sarah entered the OR, she could see that Michael was already under anesthesia. Dr. Park looked up from her monitoring equipment. "He's stable for now, but we're definitely dealing with ongoing blood loss. His hemoglobin is dropping and we've already started the first unit of blood." Sarah positioned herself at the operating table, with the surgical technician to her right and the first assistant across from her. "Let's proceed with a midline incision. We need to identify the source of bleeding quickly." The first incision revealed exactly what Sarah had suspected. Dark blood filled the abdominal cavity, confirming active internal hemorrhage. She quickly inserted suction to clear the field and began her systematic exploration of the abdominal organs. "There," she said, identifying the damaged spleen. "Grade 4 splenic laceration with active bleeding from the hilum. We're going to need to remove it." Splenectomy was a procedure Sarah had performed many times, but tonight it felt different. For the first time in months, she was the primary surgeon making critical decisions without someone looking over her shoulder or questioning her judgment. Her hands moved with confidence as she carefully isolated the splenic vessels and began the delicate process of removing the damaged organ. "Blood pressure is stabilizing," Dr. Park announced from behind her anesthesia screen. "The blood replacement seems to be keeping pace with the loss." Sarah nodded, continuing her careful dissection. "Good. Let's make sure we control all the bleeding before we close. I want to inspect the other organs thoroughly." As she worked, Sarah was aware of activity throughout the hospital. The emergency department was handling the other trauma patients, and she knew that Dr. Martinez was probably performing surgery in an adjacent operating room. Tonight, the usual hierarchy and politics had been set aside in favor of patient care. Temporary surgeon or not, Sarah was exactly where she needed to be. 20 minutes into the surgery, the circulating nurse received a phone call that immediately caught Sarah's attention. "Dr. Chen," the nurse said, "there's been a complication with one of the other trauma patients. Dr. Martinez is requesting that you assess another emergency case as soon as you're able." Sarah looked up from her surgical field. This was unusual. Typically, trauma cases were assigned to specific surgeons who saw them through to completion. For Martinez to be asking for additional help suggested that the other patients were in critical condition. "What's the situation?" Sarah asked, continuing to work on securing the last of the bleeding vessels. "A pediatric patient, 8 years old, with chest trauma. The family was in the vehicle behind the initial accident and got caught in the secondary collision. The child is showing signs of cardiac tamponade." Sarah felt her heart rate increase. Cardiac tamponade in children was one of the most challenging emergency procedures a surgeon could face. The condition occurred when blood or fluid accumulated around the heart, preventing it from beating effectively. Without immediate intervention, the patient would die within minutes. "Dr. Park, how much longer do you think we need with Michael?" Sarah asked. "His vitals are stable, and the bleeding appears controlled," the anesthesiologist replied. "If you can finish the abdominal closure in the next 5 minutes, I think he'll be ready for recovery." Sarah made a quick decision. "Let's close. I'll use a running closure technique to speed things up, and I want to make sure there are no missed bleeding sources." Her hands worked rapidly but carefully, closing the abdominal layers with efficient technique. The running suture she chose was faster than interrupted sutures but required more skill to ensure proper healing. Sarah had perfected this technique during her trauma training, recognizing that emergency situations often required balancing speed with surgical quality. As she placed the final skin staples, Sarah was already thinking about the next case. Pediatric cardiac tamponade required specialized knowledge and experience. She had performed the procedure twice during her residency and had assisted on 3 additional cases during her trauma surgery training. It wasn't common, but it was within her capabilities. "Michael's doing well," Dr. Park announced as the monitors showed stable vital signs. "Blood pressure is 110/70, heart rate has normalized, and his oxygen levels are excellent." Sarah stripped off her surgical gown and gloves, briefly reviewing Michael's postoperative care with the recovery room nurse. "Monitor his vital signs closely for the next 4 hours. If there's any drop in blood pressure or signs of bleeding, call me immediately. He'll need antibiotics because of the splenectomy, and we should discuss vaccination schedules with his family tomorrow." The recovery room nurse nodded, already familiar with post-splenectomy protocols. Sarah appreciated that she didn't need to over-explain the care requirements. The nursing staff at St. Mary's was experienced and competent. As Sarah hurried toward the pediatric emergency area, she encountered Dr. Kevin Walsh in the hallway. Kevin looked surprised to see her in surgical scrubs, clearly coming from an operating room rather than an observation role. "Dr. Chen? I thought you were off tonight. What are you doing here?" Sarah didn't slow her pace. "Emergency trauma call. Multiple casualties from a highway accident." Kevin's expression shifted from surprise to something resembling concern. "Wait, you're not operating independently, are you?" I mean, temporary surgeons need supervision for major procedures. That's hospital policy. Sarah stopped walking and turned to face Kevin directly. Dr. Walsh, there are critically injured patients who need immediate surgical intervention. Dr. Martinez requested my assistance based on my trauma surgery experience. Are you suggesting that hospital policy is more important than saving lives? The question hung in the air between them. Kevin clearly recognized that challenging Sarah's involvement in emergency care would put him in an indefensible position. Hospital politics might dictate observer roles for temporary surgeons during routine cases, but emergency situations operated under different rules. Of course not, Kevin replied, but his tone suggested he was already planning to report this incident to Dr. Webb. I'm just making sure everyone understands the appropriate protocols. Sarah resumed walking toward the pediatric unit. The appropriate protocol tonight is saving lives, Dr. Walsh. I suggest you focus on that. The pediatric emergency area was smaller than the adult trauma section but equally well-equipped. Sarah found Dr. Martinez standing beside a small gurney where an 8-year-old girl lay unconscious, surrounded by monitors and medical equipment. The child's parents stood nearby, their faces showing the particular terror that came with watching their child's life hang in the balance. This is Emma Rodriguez, Dr. Martinez said quietly as Sarah approached. 8 years old, passenger in Vehicle 3. Initially seemed stable, but she's developed classic signs of cardiac tamponade over the last 20 minutes. Her neck veins are distended, blood pressure is dropping, and heart sounds are muffled. Sarah looked at the small patient, her mind automatically reviewing the anatomy and procedure for pediatric cardiac tamponade. The surgery itself was not dramatically different from the adult version, but children's smaller size and different physiological responses required modified techniques and extreme precision. What's her current blood pressure? Sarah asked, reviewing the monitors. 70/40 and dropping, replied the pediatric nurse. Heart rate is 140 and climbing. Sarah nodded, recognizing the classic signs of impending cardiac arrest. We need to move to the OR immediately. This can't wait for additional imaging or consultation. Dr. Martinez looked relieved to hear Sarah's decisive response. I was hoping you'd say that. I've done this procedure twice, but not in the last 5 years. Your trauma experience makes you the best choice for primary surgeon. As they prepared to transport Emma to the pediatric operating room, Sarah knelt beside the child's parents. The father appeared to be in his 30s, with grease stains on his work shirt suggesting he had been called directly from his job. The mother looked younger, her eyes red from crying but focused intently on every word the medical staff spoke. Mr. and Mrs. Rodriguez, Sarah said gently, my name is Dr. Chen. Emma has developed a condition where fluid is pressing against her heart, making it difficult for the heart to beat properly. We need to take her to surgery right away to relieve that pressure. Is she going to be okay? The mother asked, her voice barely above a whisper. Sarah met her eyes directly. This is a serious condition, but it's something we know how to treat. The surgery involves making a small opening to drain the fluid around her heart. I've performed this procedure before, and Emma is young and strong. We're going to take very good care of her. The father stepped forward. Are you? I mean, how many times have you done this surgery? Sarah understood his concern. If she were a parent, she would want to know everything about the surgeon operating on her child. I've performed this specific procedure 5 times, and I've been a trauma surgeon for 8 years. Dr. Martinez will be assisting me, and we have an excellent pediatric anesthesia team. Thank you, the mother said, reaching out to briefly touch Sarah's arm. Please save our little girl. As they moved Emma toward the operating room, Sarah felt the weight of responsibility that came with pediatric surgery. Adult patients chose to trust their surgeons, but children had no choice in the matter. Their lives depended entirely on the skill and judgment of the medical team. The pediatric operating room was configured differently from the adult ORs, with smaller instruments and equipment designed specifically for children. Dr. Sandra Kim, the pediatric anesthesiologist, was already preparing for the case. This is going to be challenging, Dr. Kim said as she reviewed Emma's vital signs. Her cardiac function is already compromised, and anesthesia could further stress her system. We'll need to work quickly. Sarah scrubbed in for the second time that night, her mind focused on the technical details of the upcoming procedure. Pediatric cardiac surgery required absolute precision. The child's heart was small, the surrounding structures were delicate, and there was no margin for error. As she entered the operating room, Sarah could see that Emma looked even smaller on the adult-sized operating table. The monitors showed her vital signs continuing to deteriorate despite the medical team's efforts to stabilize her condition. Blood pressure is now 60/30, Dr. Kim announced. We need to proceed immediately. Sarah positioned herself at the operating table, with Dr. Martinez across from her as first assistant. The surgical technician had prepared the specialized pediatric instruments, and the circulating nurse confirmed the patient identification and procedure. Emma Rodriguez, emergency pericardiocentesis and possible pericardial window for cardiac tamponade, the nurse announced. Confirmed, Sarah replied, accepting the scalpel from the surgical technician. Let's save this little girl's life. The first incision into Emma's chest revealed the critical situation Sarah had anticipated. Dark blood and fluid surrounded the child's heart, creating the life-threatening pressure that was preventing normal cardiac function. Sarah worked with meticulous precision, her movements deliberate and controlled despite the urgent nature of the situation. There's significant hemopericardium, Sarah observed, carefully inserting suction to remove the accumulated blood. More than I expected from the mechanism of injury. Dr. Martinez leaned closer to observe the surgical field. Could there be additional trauma we didn't identify on the initial assessment? Sarah paused her dissection to examine the heart more thoroughly. Her trained eye caught something that explained the extensive bleeding. There's a small laceration on the right atrial wall. It's not large, but, in a child this size, even minor cardiac injuries can cause significant blood accumulation. The discovery changed the complexity of the procedure. What had initially appeared to be a straightforward drainage of blood from around the heart now required delicate repair of the heart muscle itself. Sarah had performed cardiac repairs before, but never on a patient so young. Dr. Kim, how are her vital signs? Sarah asked without looking away from the surgical field. Blood pressure is responding to the drainage, the anesthesiologist replied. Up to 80/50 now. Heart rate is stabilizing around 120. The cardiac function is improving with the pressure relief. Sarah felt a surge of cautious optimism. Emma's response to the initial intervention suggested that her heart muscle was healthy and would recover well once the mechanical obstruction was removed. Now she needed to repair the small tear in the heart wall to prevent further bleeding. I'm going to need cardiovascular suture, 5-polypropylene, Sarah said to the surgical technician. And, let's have some pledgets ready in case we need to reinforce the repair. The repair itself required extraordinary precision. The child's heart was beating throughout the procedure, which meant Sarah had to time her sutures carefully to avoid disrupting the cardiac rhythm. Each stitch had to be placed with exact tension, too loose and the repair would fail, too tight and it could distort the heart's function. As Sarah worked on the cardiac repair, she became aware of commotion outside the operating room. Raised voices in the hallway suggested that word of her independent surgical procedures was spreading through the hospital. She suspected that Dr. Webb had been contacted about the temporary surgeon performing emergency operations without direct supervision. First suture placed, Sarah announced, focusing entirely on the delicate tissue in front of her. The laceration edges are coming together nicely. Dr. Martinez assisted by providing optimal visualization and helping to manage the small amount of ongoing bleeding. Your technique is excellent, Sarah. I haven't seen cardiac repair work this precise from anyone except Dr. Harrison himself. The comment was both compliment and warning. Dr. Harrison Webb was legendary at St. Mary's for his cardiac surgery skills, but he was also the chief of surgery who had been systematically excluding Sarah from meaningful cases. If her surgical ability became too apparent, it might create additional political complications. Second suture placed, Sarah continued, maintaining her focus on the technical aspects of the procedure. Politics could be dealt with later. Right now, Emma's life depended on perfect execution of this repair. The operating room door opened as Sarah was placing the final suture in the cardiac repair. She didn't look up, but she could sense the shift in atmosphere that accompanied Dr. Webb's entrance. The chief of surgery had arrived to observe the temporary surgeon who was performing unsupervised cardiac surgery on a pediatric patient. Dr. Martinez, Dr. Webb's voice carried his characteristic authority. "What exactly is happening here?" Dr. Martinez straightened slightly but continued her assistance. "Emergency cardiac tamponade in an 8-year-old trauma patient, Dr. Webb. Dr. Chen is performing the repair." Sarah completed the final stitch and carefully inspected her work. The repair appeared solid, with no signs of ongoing bleeding or tissue distortion. "Cardiac repair is complete. The laceration is sealed and there's no active hemorrhage." She finally looked up to acknowledge Dr. Webb's presence. The chief of surgery stood behind the anesthesiologist, his expression unreadable behind his surgical mask. His eyes, however, were focused intently on the surgical field and Sarah's technique. "Dr. Chen," Dr. Webb said formally, "this is a significant procedure to be performing without consultation or supervision." Sarah continued her careful inspection of the heart and surrounding structures. "Dr. Webb, this child was dying from cardiac tamponade. The decision tree was straightforward: emergency surgery or cardiac arrest. Dr. Martinez requested my assistance based on my trauma surgery experience." "I see." Dr. Webb moved closer to observe the surgical field directly. Sarah was acutely aware that her work was being scrutinized by one of the most respected cardiac surgeons in the region. Every aspect of her technique, from instrument handling to tissue management, was being evaluated. Dr. Kim interrupted the tension with a clinical update. "Blood pressure is now 95/60. Heart rate has normalized to 100. Cardiac output appears excellent. The repair is holding perfectly." Sarah began the process of closing the chest, carefully placing drainage tubes to prevent fluid reaccumulation and ensuring that all bleeding was controlled. The final steps of the procedure required the same precision as the cardiac repair, but the most critical work was complete. As Sarah worked on the chest closure, Dr. Webb asked quietly, "Where did you complete your cardiac surgery training?" "I did a trauma surgery fellowship at Denver General," Sarah replied, placing careful sutures in the chest wall. "The program included extensive cardiac trauma training because of the high-altitude rescue cases we handled. Mountain climbing accidents, skiing injuries, things that often involve chest trauma." Dr. Webb nodded thoughtfully. "Dr. Harrison at Denver General. I know his work. Excellent trauma program." The simple acknowledgement felt significant. Dr. Webb's recognition of her training suggested that perhaps her skills were being evaluated more fairly than the hospital politics had indicated. Sarah completed the chest closure and stepped back from the operating table. "Procedure complete," she announced. "Patient is stable with excellent vital signs and no signs of ongoing bleeding." Dr. Kim was already preparing Emma for transport to the pediatric intensive care unit. "She's doing beautifully. I think we're going to see a full recovery." As the surgical team prepared to move Emma to recovery, Dr. Webb approached Sarah. "Dr. Chen, I'd like to speak with you after you've completed your post-operative documentation." Sarah nodded, uncertain whether the conversation would be positive or disciplinary. "Of course, Dr. Webb." Before leaving the operating room, Sarah stopped to speak with Emma's parents, who had been waiting anxiously in the family conference room. Their faces showed the exhaustion and fear that accompanied watching their child undergo emergency surgery. "The surgery went very well," Sarah told them as they stood to hear the update. "We found that Emma had developed pressure around her heart from the accident, and there was a small tear in the heart muscle that needed repair. We've fixed both problems, and her heart is working normally now." Emma's mother began crying with relief. "Is she going to be okay? No permanent damage?" "Children recover remarkably well from this type of injury," Sarah assured her. "The heart muscle heals completely, and we don't expect any long-term complications. She'll need to stay in the intensive care unit for a few days for monitoring, but her prognosis is excellent." The father shook Sarah's hand firmly. "Doctor, we don't know how to thank you." When they said she needed heart surgery. His voice trailed off as emotion overtook him. "You don't need to thank me," Sarah replied gently. "This is what we're here for. Emma is a strong little girl, and she's going to do great." After ensuring that Emma was stable in the pediatric ICU and completing her surgical documentation, Sarah made her way to Dr. Webb's office. The chief of surgery's office was located on the top floor of the hospital, with large windows overlooking the city and walls lined with certificates, awards, and photographs from his distinguished career. Dr. Webb was reviewing patient files when Sarah knocked on his open door. He gestured for her to take a seat in one of the leather chairs facing his desk. "Dr. Chen, I've been reviewing your surgical record from tonight," Dr. Webb began, his tone neutral. "2 emergency procedures, both with excellent outcomes. The splenectomy was textbook, and the cardiac repair was." He paused, searching for words, exceptional. Sarah waited for the criticism she assumed was coming. Instead, Dr. Webb continued with an unexpected observation. "I also received a call from Dr. Amanda Foster in emergency medicine. She provided some interesting perspective on your role here at St. Mary's and her observations about your clinical capabilities." Sarah had not expected Amanda to advocate on her behalf, especially not directly to the chief of surgery. "Dr. Foster has been very supportive of my work here." "Yes, and her observations have caused me to reflect on some of our staffing decisions." Dr. Webb leaned back in his chair. "Dr. Chen, I'm going to be direct with you. When you first arrived here, I made assumptions about temporary surgeons that were based on previous experiences with short-term staff. Those assumptions were unfair and, frankly, incorrect in your case." The admission surprised Sarah. She had expected defensiveness or justification of the hospital's treatment of temporary staff, not acknowledgement of misjudgment. "I appreciate that, Dr. Webb. I understand that integrating temporary staff can be challenging for established surgical teams. Tonight's emergency response demonstrated something important," Dr. Webb continued. "Patient care suffered because we weren't utilizing your expertise effectively. Dr. Martinez had to handle multiple trauma cases simultaneously because we had relegated you to observer status. That's not acceptable from a quality of care perspective." Sarah remained silent, unsure where the conversation was heading. Dr. Webb's tone suggested that significant changes might be forthcoming, but she had learned to be cautious about reading too much into administrative conversations. "I'm going to make some immediate changes to your assignment here," Dr. Webb announced. "Effective tomorrow, you'll be added to the emergency surgery call schedule. Dr. Martinez will orient you to our trauma protocols, and you'll have full privileges for emergency procedures within your scope of practice." The offer was more than Sarah had hoped for when she first arrived at St. Mary's. Full emergency surgery privileges would allow her to function as a complete member of the surgical team rather than a marginalized observer. "Thank you, Dr. Webb. I appreciate the confidence you're placing in me." "There's more," Dr. Webb continued. "I've also been in contact with the administration about extending your assignment here. Dr. Rivera's family situation has become more complex, and he's requested an additional 6-month leave. If you're interested, we'd like to offer you a longer-term contract with full surgical privileges." The extended contract represented a significant opportunity. 6 more months at St. Mary's would provide valuable experience and potentially open doors to permanent positions at prestigious hospitals. It would also mean postponing other opportunities Sarah had been considering. "Can I take some time to consider the offer?" Sarah asked. "Of course. Take whatever time you need." Dr. Webb stood from his chair, indicating that the meeting was concluding. "Dr. Chen, I want you to know that tonight reminded me why we became doctors in the first place. Your surgical skill and judgment under pressure were exactly what those patients needed. Thank you for your excellent work." As Sarah left Dr. Webb's office, her phone buzzed with a message from Dr. Martinez. "Emergency department just received another trauma alert. Multi-vehicle accident on the bridge, ETA 15 minutes. You available for another round?" Sarah smiled as she typed her response. On my way down. The elevator ride to the emergency department felt different this time. Instead of responding as a temporary surgeon hoping to prove herself, she was responding as a valued member of the trauma team. The political barriers that had constrained her work for months had been swept away by the reality of emergency patient care. When the elevator doors opened, Sarah could see the familiar controlled urgency of trauma preparation. Nurses were preparing equipment, residents were reviewing protocols, and the entire emergency department was mobilizing for the incoming casualties. Dr. Martinez spotted Sarah immediately and waved her over to the central command station. 3 patients this time, all adults. One with suspected chest trauma, one with head injury, and one with multiple fractures. What do you think about taking primary on the chest trauma? Sarah nodded without hesitation. Absolutely. What's the ETA? 12 minutes for the first ambulance. The paramedic report suggests pneumothorax with possible cardiac involvement. As Sarah prepared for her 3rd emergency surgery of the night, she reflected on how dramatically the evening had changed her situation at St. Mary's. The temporary surgeon they had ridiculed was now being sought out for the most complex cases. Her surgical skills had finally been recognized not through politics or connections, but through the most important measure of all, her ability to save lives when it mattered most. The emergency department doors opened as the first ambulance arrived, and Sarah stepped forward to meet the next patient who would need her expertise. Tonight had proven that excellent surgery transcended hospital politics, and that patient care was the ultimate measure of a surgeon's value to any medical team. The 3rd trauma patient of the night arrived exactly as the paramedics had described, a 35-year-old construction worker named David Kim, who had been driving home from his evening shift when the accident occurred. The paramedics' report painted a concerning picture of chest trauma with potential cardiac involvement, and David's deteriorating vital signs during transport confirmed the severity of his injuries. Sarah took primary responsibility for David's care as soon as the ambulance doors opened. His breathing was labored, his skin was pale and clammy, and the characteristic signs of shock were becoming more apparent with each passing minute. The paramedics had inserted a chest tube during transport, but David's condition continued to worsen. Blood pressure is 70/40 and dropping, announced the paramedic as they transferred David to the hospital gurney. We've given him 2 liters of fluid and started high-flow oxygen, but his respiratory distress is increasing. Sarah immediately began her assessment, listening to David's chest with her stethoscope. The breath sounds on the right side were significantly diminished, and she could feel the subtle movement of air under the skin that indicated a pneumothorax. More concerning, however, were the irregular heart sounds that suggested possible cardiac injury. David, can you hear me? Sarah asked, leaning close to her patient. My name is Dr. Chen. You've been in an accident, and we're going to take care of you. David's eyes opened briefly, but his response was weak and unfocused. Can't breathe, he whispered. Sarah nodded, her hands continuing their rapid assessment. I know it's hard to breathe right now. We're going to fix that. You're in good hands. The trauma team worked efficiently around her, establishing additional 4 access, sending blood samples for immediate analysis, and preparing for the possibility of emergency surgery. Sarah's mind was already processing the clinical information and developing a surgical plan. Get me a portable chest X-ray immediately, Sarah instructed. And I want cardiothoracic surgery notified. We may need to open his chest. Dr. Martinez appeared at Sarah's side, having completed her assessment of the 2nd trauma patient. What's your read on this one? Significant pneumothorax, but the chest tube isn't improving his respiratory status as much as it should, Sarah replied, palpating David's chest wall. I'm also hearing irregular heart sounds that suggest possible cardiac contusion or worse. His shock seems out of proportion to the pneumothorax alone. The portable X-ray results appeared on the monitor within minutes, confirming Sarah's clinical suspicions. David's right lung was partially collapsed despite the chest tube, but, more significantly, the X-ray showed a widened mediastinum that could indicate bleeding around the heart or major blood vessels. That mediastinal widening is concerning, Dr. Martinez observed. Could be aortic injury. Sarah felt her pulse quicken. Traumatic aortic injury was one of the most dangerous complications of chest trauma. If the aorta had been damaged in the accident, David could suffer catastrophic internal bleeding at any moment. The condition required immediate surgical intervention and carried significant risk even with prompt treatment. "We need to move to the OR immediately," Sarah declared. "This can't wait for additional imaging." His clinical presentation suggests imminent cardiovascular collapse. As the trauma team prepared to transport David to the operating room, Sarah noticed Dr. Kevin Walsh observing from across the emergency department. Kevin's presence reminded her that news of her successful surgeries had undoubtedly spread throughout the hospital, and not everyone would be pleased with a temporary surgeon taking primary responsibility for complex cases. Dr. Webb appeared as they were moving David toward the elevator. "Dr. Chen, what's the assessment?" "Pneumothorax with possible aortic injury," Sarah replied, not breaking stride. "The mediastinal widening and hemodynamic instability suggest major vessel trauma. He needs emergency thoracotomy." Dr. Webb nodded grimly. "That's a high-risk procedure. Are you comfortable proceeding independently?" The question carried multiple layers of meaning. Dr. Webb was not only asking about Sarah's technical capability but also giving her the opportunity to request assistance or supervision if she felt it was needed. The fact that he was offering her the choice represented a significant shift from the hospital's previous treatment of temporary staff. "I've performed emergency aortic repairs before," Sarah replied confidently. "Dr. Martinez will assist, and I recommend we have vascular surgery standing by in case we encounter complications beyond the aortic injury." "Agreed. Dr. Patterson from vascular surgery is on his way in." The operating room was prepared for cardiovascular surgery when they arrived, with the specialized instruments and equipment needed for major vessel repair. Dr. Park, the anesthesiologist from Emma's surgery, had been called back for this case, bringing her experience with emergency cardiac procedures. "This is our third emergency tonight," Dr. Park observed as she prepared David for anesthesia. "His blood pressure is marginal, and we're looking at another high-risk case." Sarah scrubbed in for the third time in one evening, her mind focused on the technical challenges ahead. Aortic repair required absolute precision and often involved working on a beating heart while managing significant blood loss. The procedure combined the urgency of trauma surgery with the delicacy of cardiac surgery. As Sarah entered the operating room, she could see that David's condition had continued to deteriorate. The monitors showed dropping blood pressure and irregular heart rhythms that suggested his cardiovascular system was failing. "Blood pressure is now 60/30, Dr. Park announced. "Heart rate is 140 and irregular. We need to proceed immediately." Sarah positioned herself at the operating table, accepting the scalpel from the surgical technician. "We're going to perform an emergency thoracotomy through the left chest. Dr. Martinez, I'll need you to help with visualization and bleeding control." The first incision revealed the extent of David's injuries. Dark blood filled the chest cavity, and Sarah could immediately see that her suspicions about aortic trauma were correct. The ascending aorta showed a partial tear that was actively bleeding, creating the life-threatening blood loss that had caused David's shock. "There's the problem," Sarah announced, carefully inserting suction to clear the surgical field. "Partial aortic transection. We need to control this bleeding immediately." Aortic repair required temporary control of blood flow while the vessel was repaired, a delicate balance between stopping the bleeding and maintaining circulation to vital organs. Sarah had performed this procedure twice during her trauma fellowship, but each case presented unique anatomical challenges. "I'm going to need vascular clamps and Gore-Tex patch material," Sarah said, carefully examining the extent of the aortic injury. "The tear is about 3 centimeters long, but it doesn't appear to involve the full circumference of the vessel." Dr. Patterson from vascular surgery arrived as Sarah was beginning the repair. "Dr. Chen, what can I do to assist?" Sarah appreciated the collaborative approach. "The injury appears to be within my capabilities, but I'd like you to scrub in and observe. If we encounter unexpected complications or if the repair doesn't hold, I may need your expertise." Dr. Patterson nodded and began scrubbing in while Sarah continued her careful dissection around the injured aorta. The repair itself required placing sutures in a major blood vessel while maintaining adequate blood pressure and avoiding damage to surrounding structures. First suture placed, Sarah announced, her movements deliberate and controlled. The tissue quality looks good. I think we can achieve a solid repair. As Sarah worked on the aortic repair, she could hear activity throughout the hospital. The emergency department was still managing the other trauma patients from the evening's accidents, and she knew that multiple surgical teams were working simultaneously to care for all the injured victims. Blood pressure is responding to the repair, Dr. Park observed from behind her anesthesia screen. Up to 75/40. Heart rhythm is stabilizing. Sarah felt a sense of cautious optimism as the repair progressed. David's vital signs were improving with each suture placed, suggesting that the aortic injury had been the primary source of his cardiovascular compromise. Second suture placed, Sarah continued, maintaining her focus on the precise placement of each stitch. The repair is holding well. No signs of ongoing bleeding. Dr. Patterson observed from his position across the table. Your technique is excellent, Dr. Chen. That's one of the cleanest aortic repairs I've seen under emergency conditions. As Sarah placed the final sutures in the aortic repair, the operating room door opened again. She looked up to see Dr. Webb entering with two other individuals she didn't immediately recognize. One was an older man in an expensive suit, and the other was a younger woman carrying a tablet. Dr. Chen, Dr. Webb said formally, I'd like you to meet Dr. Robert Harrison, chairman of our hospital board, and Ms. Jennifer Walsh, our media relations director. Sarah felt a moment of confusion. Hospital board members and media relations staff didn't typically observe ongoing surgeries, especially emergency procedures. She continued her work on the aortic repair while trying to understand why these individuals were present. Dr. Chen, Dr. Harrison said, moving closer to observe the surgical field, I understand you've performed 3 life-saving surgeries tonight. 3 patients who might not have survived without your expertise. Sarah completed the final suture and carefully inspected her repair work. The patients received excellent care from entire trauma teams, Dr. Harrison. Surgery is always a collaborative effort. Nevertheless, Dr. Harrison continued, your individual contributions have been remarkable. Ms. Walsh has received inquiries from local news outlets about tonight's emergency response. Apparently, family members of the patients have been speaking to reporters about the excellent care their loved ones received. Sarah looked up from the surgical field, suddenly, understanding the presence of media relations staff. I'm not comfortable with media attention, Dr. Harrison. These patients deserve privacy, and their families are dealing with traumatic situations. Ms. Walsh spoke up for the first time. Dr. Chen, the families specifically mentioned wanting to thank you publicly. They feel that your surgical skill saved their family members' lives. The story would focus on the excellent emergency care provided at St. Mary's. Dr. Webb intervened. Sarah, obviously any media participation would be entirely voluntary. But I think Dr. Harrison is trying to address something more significant than just tonight's cases. Dr. Harrison nodded. Dr. Chen, your surgical performance tonight has prompted some important discussions among the hospital leadership. We've been reviewing your credentials, your surgical outcomes, and the feedback from staff who have worked with you. Sarah completed her inspection of the aortic repair and began preparing to close David's chest. I appreciate the review, but I'm focused on completing this surgery successfully. Of course, Dr. Harrison agreed. But I want you to know that we're prepared to offer you a permanent position on our surgical staff. Full privileges, participation in our cardiac surgery program, and the opportunity to develop a trauma surgery specialty here at St. Mary's. The offer was unexpected and significant. A permanent position at St. Mary's represented a major career opportunity, but it also meant committing to the hospital that had initially marginalized her abilities. Dr. Harrison, I appreciate the offer, but I need to focus on my patient right now. Can we discuss this after I've completed the surgery? Absolutely. Take all the time you need. As the hospital leadership left the operating room, Sarah continued the careful process of closing David's chest. Her mind was processing not only the technical aspects of the surgery but also the unexpected turn her career at St. Mary's had taken in a single evening. Blood pressure is now 90/60, Dr. Park announced. Heart rate has normalized to 95. The repair is holding perfectly. Sarah placed the final chest tube and began closing the skin incision. Surgery complete. Patient is stable with excellent vital signs and no signs of ongoing bleeding. Dr. Patterson helped remove the surgical drapes. That was excellent work, Dr. Chen. I couldn't have done the repair any better myself. As David was prepared for transport to the cardiac intensive care unit, Sarah reflected on the extraordinary events of the evening. In the space of 8 hours, she had performed 3 life-saving surgeries, earned the respect of her colleagues, and received an offer for the permanent position she had originally hoped to achieve at St. Mary's. The temporary surgeon who had been ridiculed and marginalized had proven her worth in the most definitive way possible, by saving lives when it mattered most. Tonight had demonstrated that surgical excellence transcended hospital politics and that patient care was the ultimate measure of a physician's value. As Sarah completed her post-operative documentation and checked on her 3 patients in their respective intensive care units, she knew that her career had reached a turning point. The question now was whether she would choose to stay at St. Mary's or continue pursuing opportunities elsewhere. Michael Torres was awake and talking with his family, his post-splenectomy recovery proceeding exactly as expected. Emma Rodriguez was sleeping peacefully in the pediatric ICU, her parents maintaining a bedside vigil but no longer fearing for their daughter's life. David Kim remained sedated but stable, his aortic repair holding perfectly and his vital signs indicating that he would make a full recovery. 3 patients. 3 successful surgeries. 3 lives saved by a temporary surgeon who had finally been given the opportunity to demonstrate her true capabilities. As Sarah drove home through the early morning city streets, she realized that tonight had changed not only her standing at St. Mary's but also her understanding of her own professional worth. She was no longer the temporary surgeon hoping for acceptance. She was simply a surgeon who had done her job exceptionally well when it mattered most.